Assalamu alaikum. This lecture is about spine tumors. These slides are from a tumor course in Cleveland Clinic in 2018, and I found them useful and informative and regarding spine tumors. So, bone pain is not adequately treated by many physicians. Patients at times experience sequential complications over a period of several years. In addition to pain, patient can experience loss of mobility, skeletal fractures, hypercalcemia, spinal cord and nerve root compression because of a tumor involvement. Now, how would we classify spine tumors? Spine tumors can involve the spine column or the spinal cord itself. They can be classified into benign or malignant. Anatomically, they are subclassified into extradural, intradural, but they are extramedullary, يعني they are intradural tumors, but they are extramedullary, يعني outside the spinal cord parenchyma, or tumors that involve the spinal cord itself, so they are intramedullary. This is a schematic representation of spine tumors. Classification of spinal tumors, they are either primary or secondary, metastatic. Primary spinal tumors, as we said, can be extradural or intradural. Extradural, again, they are classified into benign or malignant. Extradural primary tumors like hemangiomas, aneurysmal bone cyst, giant cell tumor, osteoblastomas, osteoid osteomas, and osteochondromas. I think you took your lectures on bone tumors in general. So you have to review these lectures on bone tumors before we understand or before we can study tumors that involve the bone or the spine elements. Malignant extradural tumors are osteosarcomas, Ewing sarcomas, chordomas, chondrosarcoma, multiple myeloma, and the plasmacytoma. Metastatic tumors involve their primary site is mostly from the lung first in the male and the breast in female, followed by prostate, renal, thyroid, and gastrointestinal. Intradural tumors are of neurosurgical concern, and we will not discuss them further here. I think you can follow your neurosurgical lectures regarding intradural tumors, whether they are extramedullary or intramedullary. Tumors that involve the bone, they can involve the anterior elements of the spine, like giant cell tumor, osteosarcoma, eosinophilic granuloma, and ABC, or aneurysmal bone cyst. They have a predilection for vertebral body involvement, while osteoid osteoma, osteoblastoma, and Ewing sarcoma, osteochondroma, again aneurysmal bone cyst, they have a predilection for involvement of the posterior spine elements, that's to say spinous process, the lamina, and the pedicles. Benign lesions that are extradural, that arise from the vertebral body or neural arch, they are relatively uncommon. However, vertebral hemangiomas, they are the most common benign lesions that involve the vertebral body. Osteoid osteoma and osteoblastoma have a predilection for involvement of the posterior elements along with osteochondroma. Giant cell tumors and Langerhans giant cell histiocytosis, like eosinophilic granuloma, they can involve the vertebral body, and aneurysmal bone cyst can involve the body and the posterior elements. Further discussion of vertebral hemangiomas, because they are the most common, and in MRI they appear as increased signal intensity on T2 weighted images. They can involve the vertebral body, and they can be isolated, single or multi-level involvement. They occur in about 10 to 12% of autopsy series. They are common. They are hematomatous proliferation of vasogenic and endothelial tissue in the bone. They are not true tumors. They are hematomas. 1/3 of patients have multiple levels of involvement. And they are asymptomatic. They are incidentally identified with MRI. But they can or they may enlarge, causing pain or neurologic deficit from spinal cord compression or pathologic fracture. So these lesions should be aggressively approached and treated. Symptomatic lesions usually present in the cervical or in the dorsal spine, in the thoracic spine. Why? Because the spinal canal in the thoracic region is narrow, so it can present with a neurological involvement. A patient with vertebral hemangioma, if he is asymptomatic, no need for treatment, just follow up. X-ray therapy or deep X-ray therapy often results in sclerotic obliteration of the hemangioma if it is symptomatic. For example, a patient presents with pain. So pain improves over months or years with deep X-ray therapy. Post-operatively, for incomplete removal, if the patient presents, for example, with hemangioma at the spinal cord involvement, 20 to 30% they reoccur within 2 years. If we use adjuvant X-ray therapy, the recurrence rate will be reduced to 7%. SRS is stereotactic radiosurgery, and we will, in the next slides, we will see what we mean by SRS. Embolization will cause more rapid pain relief, but there is a risk of cord infarction, should be approached carefully. Ethanol injection directly into the hemangioma will cause sclerosis of the blood spaces. Vertebral augmentation with bone cement. Bone cement is what we call polymethyl methacrylate اللي يستخدم بالحشوة المؤقتة مع الأسنان. Bone cement can be injected into the vertebral body through the pedicle. This process is called vertebroplasty or kyphoplasty. We inject semi-viscous bone cement through the pedicle, through a cannula that passes through the pedicle and to the vertebral body, and this bone cement will cure and will get solidified and obliterate the cavernous hemangioma. Surgery might be indicated for radical excision and reconstruction. Osteoid osteoma is similar to osteoblastoma histologically. They cannot be differentiated by histopathology. They are differentiated only by size. If the lesion is less than 1.5 cm, it is an osteoid osteoma, and osteoid osteoma has a nidus, as is shown here in the pedicle of the vertebra. This nidus is a reactive fibrovascular tissue that will cause pain, and this pain is characteristically nocturnal pain, response to aspirin and non-steroidal anti-inflammatory drugs. these patients present with back pain, and because of the pain, the patient will develop a spasm of the paraspinal muscles with scoliotic deformity. And the lesion is in the concavity of the scoliotic curve. Treatment is either with non-steroidal anti-inflammatory drugs, or we can obliterate the nidus, as is shown here, with thermal ablation. There is a device called radiofrequency ablation that will generate heat, and the heat will cauterize the inflammatory fibrovascular tissue within the nidus of the lesion, and the pain will get resolved. Or we can do surgical resection of the osteoma, and the patient will get again permanent relief. As we said, osteoblastoma is a lesion with more than 2 cm of size of involvement, as in this slide. It usually involves the neural arch, the posterior arch of the vertebra, and it has a predilection on the second or third decade of life. It is more aggressive and may have cortical breach and soft tissue expansion. Up to about half of the cases occur in the spine, and usually these patients present with back pain and scoliosis. Treatment is with resection, with a close follow-up for recurrence or secondary malignant transformation. So we have to resect, and if the patient gets instability, we may stabilize with instrumental diffusion. Another type of benign tumor involvement in the spine is the aneurysmal bone cyst. And aneurysmal bone cyst is a cystic lesion in the bone with aneurysmal expansion of the cyst. So the cyst will expand into aneurysmal proportions. It appears as a soap bubble-like appearance with expansion of the bone. It is rare, and 8 to 30% of the ABCs occur in the spine, but it is locally aggressive. It can cause spinal cord compression, and it has a predilection for the second and third decade. Usually these patients present with pain. It is the third most common primary bone tumor after osteoid, osteoma, and osteoblastoma. It commonly occurs in the lumbar spine or in the cervical spine, and it constitutes about 50% of primary bone tumors in the spine. Treatment is either adjuvant treatment or with resection. Giant cell tumor can involve the vertebral body. Histologically, it is characterized by osteoclast-like giant cells within a spinal stroma. The spinal stroma consists of spindle-like cells. They are the neoplastic component of the lesion, yani giant cell tumor. The presence of osteoclasts characterize the lesion as giant cell tumor, but the neoplastic stroma is something different. So less than 10% of giant cell tumors occur in the spine. 50% of giant cell tumors of the spine occur in the sacrum. They have a high probability of local recurrence. They are locally aggressive and associated with high rate of local recurrence. They require multiple surgeries or adjuvant radiation. It can transform into sarcoma. Now, sarcomas, sarcoma is a tumor of connective tissue. Tumors of connective tissue, yani bone, cartilage, blood, we call them sarcoma. Tumors of endothelia or epithelia, سميها carcinoma. If you use curettage only, these lesions have a 20% rate of recurrence. Malignant tumors can involve the spine, like osteogenic sarcoma, Ewing sarcoma, chondrosarcoma, and chordoma. Plasmacytoma is a tumor of plasma cells. It is a collection of malignant hematopoietic cells in the marrow, so we need to do bone marrow aspirate or biopsy. It can present as a solitary lesion or with multiple involvement, multiple myeloma. Now, multiple myeloma is the most common primary bone tumor in the 40s. I encourage you to read more about multiple myeloma in your medicine hematology books. It is common in the spine. It presents with generalized osteopenia or lytic generalized or multiple lytic lesions. It can present with multiple osteopenic fractures because of the lytic process and because of expansion of the malignant plasma cells within the bone marrow of the vertebrae or the vertebral body. The skull involvement is represented by multiple punched out lesions. These patients characteristically, they have pain, diffuse back pain associated with constitutional symptoms. The pain is of red flag signs. Characteristically, these patients are present with high ESR above 100, hypercalcemia, renal involvement, and a predilection for infection. It is an important subject that you should read about or should know about in your medicine, hematology, and oncology books. Second type of malignant tumors that involve the spine is Ewing sarcoma. It is uncommon, but 50% of spine involvement is in the sacrum. It is a small round cell sarcoma. The Ewing sarcoma responds to aggressive chemotherapy. Surgery has a role in the resection or debulking of the tumor and radiotherapy. The third type of tumor that involves the spine is osteosarcoma. It is a high-grade spindle cell neoplasm filled with malignant osteoid or immature woven osteoid. It is unusual in the spine and may develop in post-radiation fields. Treatment is with chemotherapy, neoadjuvant and adjuvant chemotherapy, and surgery. Now, chordoma. Chordoma is a tumor that develops in the remnants of the notochord. Sacrum presents 50% of involvement by chordoma, while the spheno-occipital bone in 35 to 40%. It has a predilection for the fourth or the fifth decade of life. It is the most common malignant primary tumor of the sacrum. Metastasis develops in 30% of sacral lesions. It can present with low back pain, sciatica, or pressure symptoms like urinary and bowel symptoms and constipations, or neurologic deficit. It is a malignant tumor. It has a predilection for the sacrum. Another important topic to discuss in spine tumors is spine secondaries or spine metastases. Metastatic involvement of the spinal column can occur in 50% of patients diagnosed with cancer. Nowadays, we are seeing more of spine metastases because of the increased life expectancy of the people or the population in general and improved medical care. Detection of spine secondaries is important because they are painful and they can cause neurologic involvement, and we can treat these patients, but treatment here is usually palliative. It can lead to devastating sequelae like pain, neurologic deterioration, and involvement of the bowel or bladder with sphincter control deficiency. 70% of spine metastases are in the thoracic spine, and they are symptomatic also. So, a message that you should know is that a patient after 40 will present to you with pain in the dorsal spine or in the interscapular region should be investigated thoroughly, including MRI, because this dorsal spine are usually stable because of the presence of the rib cage. So if you have a pain that is with red flag signs in the dorsal spine or the interscapular region, an MRI should be investigated in this patient to rule out the presence of dorsal or thoracic spine involvement because of tumors or secondaries. 20% of secondaries occur in the lumbar or the sacral area, and 10% in the cervical spine. Another important thing to consider is that spine secondaries is mostly an anterior disease. So it involves 80% involves the vertebral body, with secondary involvement of the pedicle. Posterior elements occur in just 20%, the same as in TB spine. So it is an anterior element disease. 80% involve the vertebral body. But involvement of the vertebral body cannot be detected radiologically by X-ray or plain X-ray, because you have to get destruction of 30 to 50% of the bone or the mineral content of bone to be visible on X-ray as a lytic lesion. That's why MRI is more sensitive in detecting secondary spinal involvement than plain X-ray. In the previous slides, they are delineating the, as we said, the pain with red flag signs, pain because of secondary tumor involvement of the spine. Pain may develop because of mechanical instability. In the atlantoaxial region, between the atlas and the axis, neck rotation will cause pain, and the cervical spine flexion, the extension of the spine will elicit pain, and the dorsal spine extension will elicit the pain. In the history, these patients characteristically sleep upright in chair to get relief of their pain. In the lumbar spine, mechanical radiculopathy with axial loading. That's to say, they get increased pain or leg pain on sitting or standing. These symptoms need to be assessed by a spine surgeon. Examination of sensation is very important in every aspect in spine diseases. 70 to 80% of patients with neurological involvement because of spine secondaries presents with sensory loss or hyposthesia, while motor involvement in the form of paraparesis or paraplegia occur in less than 60% or less than 60%. 11 to 34% of patients with spinal cord compression are still ambulatory at diagnosis. Now, spinal cord compression because of spine secondaries presents with progressive loss of neurologic function. And this should be detected by careful neurological examination of the patient with the spine secondaries. If the patient presents with complete loss of function, for example, paraplegia or quadriplegia of more than 12 to 24 hours, this will result in permanent loss of motor function. So if the patient presents with severe motor weakness, this patient should be treated on an emergency base. Either the treatment either involves the radiation oncologist, that's to say, we use deep X-ray therapy, radiation, and the spine surgeon. The spine surgeon should be involved in decompressing the spinal cord or the compressed neural structures. This is an important slide. A patient with spine secondaries is approached according to what we call NOMS criteria. NOMS is these are abbreviation of N regarding neurologic evaluation, as we said, a careful neurologic examination that involves the sensation and motor examination, the reflexes and tone and so on. Oncologic evaluation of the patient. This involves the sensitivity of the tumor to radiation, whether there is mechanical stability or instability in the spine, and systemic evaluation of the patient. These are what we call NOMS criteria. So the approach to patient with spine secondaries is according to NOMS criteria, and we will elaborate on them now. Neurologic involvement is according to grades that represent the degree or the extent of neural compression or the extent of vertebral compression. And this is the schematic representation of the 6-point grade on epidural spinal cord compression grading scale. And this is just, you know, how the tumor can cause or can approach the neural tissue, the spinal cord. This table showing the expected response to radiation. Lymphomas, seminoma, and myeloma have favorable response to radiation. Breast, prostate, sarcoma, and this slide showing the response of, or the expected response of the tumors that are metastasizing to the spine to radiation. And this is what we call the oncologic evaluation of the tumor. So neurologic, oncologic, third is mechanical instability. So mechanical instability is according to this scale, and this is just that you know how we evaluate a patient with a spine tumor. This scale is called SINS scale, Spinal Instability Neoplastic Score, SINS scale. It involves the location, the pain, the bone lesion, whether it's lytic or mixed or blastic, vertebral body involvement, radiographic spine alignment, and so on. And these are important regarding the assessment of the stability of the lesion. And assessment of spine stability with the tumor in the patient with the spine secondaries is important if we are going to do surgical stabilization for the patient. As an indication for surgery. Systemic assessment of the patient with spine secondaries include generalized assessment. Is the patient too ill for surgery? widespread systemic disease, the options to treat, whether the patient has comorbidities, and concerns of wound healing, especially if the patient has a previous radiation. So you are going to face many patients with spine secondaries because tumors in general is increasing in our country. There is a six-fold increase of the incidence of tumors generally in our population. And that's why oncologic study and studying spine secondaries is important since 50% of tumors metastasize to the spine. This pathway, what you call NOMS pathway, and this slide will elaborate upon the possible treatment and possible approach of patients with spine secondaries. هذا نيل الاطلاع. Radiation treatment in a patient with spine secondaries is very important. The goals of radiation therapy is pain control. So a patient with spine secondaries cannot be adequately treated with medication only. Radiation treatment is pain curative in a patient with spine secondaries. It can restore or maintain neurologic function, prevent local progression, and provide spinal stability, provided that the tumor is radiosensitive. Recent advances in tumor management, spine secondaries, is the introduction of what we call stereotactic radiosurgery, and we will see what this means. Radiation treatment is important in spine secondaries, but the main problem that we cannot give overdose of radiation is because of the issue of cord tolerance. If we are giving an extra radiation that is outside the cord tolerance, it will develop microcirculatory thrombosis and cord infarction. That's why the cord cannot tolerate much radiation. 30 gray in 10 fractions or 20 gray in 10 fractions in the event of recurrence. And the issue with this dosing is it prevents meaningful retreatment because of cord intolerance to radiation. So external beam radiation, it will irradiate the tumor as well as the spinal cord. The spinal cord cannot tolerate that much radiation. That's why we cannot deliver too much radiation into the tumor. Adenocarcinoma characteristically is radioresistant. So it is external beam radiation is not effective in amelioration of the adenocarcinoma, metastatic adenocarcinoma. Now, with stereotactic radiosurgery, we can deliver an accurate and conformal high radiation dose to the tumor. So with this technique, we can isolate the tumor tissue from the neural tissue, and we can deliver increasing dose of radiation that will kill the tumor cells even if they are radioresistant or even if they are previously irradiated. And this is a big step advancement in tumor management. So Stereotactic radiosurgery, will cause, it is usually delivered in 1 to 5 sessions. It will cause a steep fall of dose gradients of the spinal cord, and it protects the adjacent normal structures. So it radiates the tumor while it protects new adjacent structures. The most importantly is the spinal cord. So in this way we can treat even resistant tumors. This is the device used to treat patients with radiosurgery, with stereotactic radiosurgery, SRS, and the patient should be immobilized. And you see this frame is to immobilize the patient even from his respiratory movements as much as possible. And these white dots represent the infrared markers that mark the tumor, and in this way we can deliver maximum or the maximum dose of radiation. Which patients are candidates for spinal SRS, spinal stereotactic radiosurgery? Patients with pain or tumor progression, minimal to moderate spinal cord compromise, maybe previously irradiated lesions, a patient with residual or recurrent lesion after surgical therapy. So a patient will develop recurrent lesion after surgical excision or have a residual lesion after surgical therapy can be treated with SRS to eradicate the residual tumor. And a patient with difficult surgical approaches, especially in the cervical spine or the craniocervical junction, a patient with short life expectancy, and with a patient with significant medical comorbidities. SRS, spine radiosurgery, is safe and effective with a durable symptomatic response and local control for even radio-resistant histologies, regardless of prior fractionated radiotherapy. Radiosurgery should be considered over conventional fractionated radiotherapy for the treatment of solid tumor spine metastases in the setting of oligometastatic disease and or radioresistant histology. So this is a major advancement in the treatment of spine secondaries.